Good morning, good afternoon, and good evening, everybody. You're all very welcome to the worldwide webinar by the WSPOS. This is webinar number 19 in season 2. I'm Aparna Ramasubramanian. I'm an ocular oncologist and pediatric ophthalmologist at Phoenix, USA. And today we are going to be talking about malignancies and the pediatric eye. So for today's webinar, it's going to be a very interactive session. Our presentations are going to be just brief, and we would really like to encourage maximum discussion. So please post your questions on web link, Facebook, and YouTube. You can also type your questions on the comment section. And as much as the time allows, we'll try to answer all the questions. But whatever questions are not answered will be compiled as a PDF, and it will be uploaded to the WSPOS website. So all the questions will definitely be answered, and we really encourage this to be a very interactive session. The Mentimeter questions are available on www.menti.com. And again, the passcode is 29844825. And this is the website where you have to enter the code. You can also use the QR code to scan into the Menti. If you would like to obtain attendance or participation certificates, please email to program@wspos.org and we can get you the certificates. I would also like to take this opportunity to say that this is World Retinoblastoma Week. And I would today we are not talking about retinoblastoma because it was covered in another webinar, but I would really like to reiterate the need to identify the leukocoria and for early detection retinoblastoma. I would like to introduce my co-moderator, Ashwin Reddy. Ashwin is a consultant at the London Hospital Baths Health NHS Trust and the Moorfields Eye NHS Foundation. He's a pediatric ophthalmologist and he heads the retinoblastoma services and the ophthalmology services. He's actively interested in improving care for children with retinoblastoma all over the world. He's part of the global RBNet and has developed retinoblastoma programs in Zimbabwe, Nigeria, Malawi, and Indonesia. And he is steadfast in the determination to improve retinoblastoma care all over the world. I'm going to hand over the stage to Ashwin.
Thank you very much, Aparna. So it's brilliant to be here. This is a really important webinar addressing dangerous conditions that we all have to be aware of, and we all need to try and avoid even creating. We've got 5 fantastic speakers here today, and I'd like to introduce my co-moderator who's doing a fantastic job, Aparna Ramasubramanian, who's an ocular oncologist and pediatric ophthalmologist practicing in a pediatric ophthalmologist in adult and pediatric ocular oncology, practicing in Phoenix Children's Hospital, USA. He's got a fantastic textbook, Retinoblastoma, and she has an interest in nanoparticles, melphalan, and intravitreal injections. She has, she's busy with her transplant cardiologist husband, and she has 2 kids. So if you could before, thanks. So Ganga Sundar hails from Chennai, and he is a senior consultant and head of orbit and oculofacial surgery at the National University Hospital, Singapore, president of the Singapore Society of Ophthalmic Plastic and Reconstructive Surgery, and he has been working around Asia as well, trying to improve care. On to the next slide, please. Amgad did his ophthalmology, Amgad, Dr. Eldib, did his ophthalmology residency and pediatric ophthalmology fellowships at the Research Institute of Ophthalmology in Cairo, Egypt. And then he went on to Emory University and then to Pittsburgh as well. And he joined as faculty and is an assistant professor of pediatric ophthalmology and strabismus with a special interest in pediatric glaucoma. Natalie is from Paris, and she's the director of the well-renowned Institut Curie in Paris and head of ocular oncology department. She's very well published, and she's received awards from the American Academy of Ophthalmology and from the French Society of Ophthalmology. She looks at research on orthotopic xenograft models of ocular tumors and is involved with uveal melanoma and retinoblastoma research. Kobe Peer is our most senior member of our group today, and he's still working as a professor and ex-chairman at the Department of Ophthalmology at Hadassah Hebrew University Medical Center. He served as past president of the International Society of Ocular Oncology and has been involved with the International Society of Ophthalmic Pathology as president also, and on board of trustees and vice president of ARVO. He's received many awards, including the International Blindness Prevention Award and the ARVO Joanne G. Angel Award. He's married and has 3 children and 2 grandchildren. And Swati, who I know very well, at the well-known LV Prasad Eye Institute, where she heads the ocular oncology services. She's very well published and has a great deal of research behind her, and is an ocular oncology section editor for 2 journals. She's a recipient for the Shakuntala Amir Chand Prize from the Indian Council of Medical Research and the IAPB Vision Excellence Award 2020 for her contribution to the field of ocular oncology. So, without more ado, we should start off with Swati. So Swati, if you can start, please.
Yes, thanks, Ashwin. So I'm going to share the screen. A very good morning, afternoon, or evening to wherever you're placed now. So I'll be talking about the malignant orbital tumors for the next 8 minutes. I do not have any financial disclosures to make. So I'll be talking about the orbital tumors by just talking about 4 cases, and I'll just take you through how we arrived at diagnosis in these cases. Now, this is the first case where a 7-year-old boy who presented with lesion in his right eye, which was palpable. It is obvious that there is fullness that is present and it was palpable as well. And this is the CT scan of the orbit, and it is obvious corresponding to the clinical findings that there is a mass that is present in the right orbit, a homogeneous soft tissue density mass. But if we observe carefully, there is also a mass that's present in the left orbit as well. So it is a bilateral disease. Whenever it is a bilateral disease, always think of a systemic disease. So this is a case of, clinically, we would suspect a bilateral granulocytic sarcoma or the leukemic deposits in the orbit, also known as scleroma. So what would we do next? Do we go ahead and do incisional biopsy in this case, or what would we do? So in these cases, a simple peripheral blood smear sometimes is sufficient. So that is what was done in this case. And the peripheral blood smear showed the presence of blast cells, which confirmed the diagnosis of acute leukemia. So the thing that we can learn from this case is that when a child presents with rapid onset proptosis, has bilateral soft tissue density homogeneous lesions, suspect granulocytic sarcoma, and you really do not have to do an invasive procedure. A simple peripheral blood smear can help you establish a diagnosis. With this understanding, let's go to the second case. Now, this is a child, 8-year-old boy who presented with similar history. He was misdiagnosed as having a benign condition and was even put on oral steroids. There was a mass that was palpable in the left orbit, and this is the CT scan. And you can see that it's almost similar the way it looks to the previous case, just that it is not bilateral. It is a unilateral lesion, but a homogeneous soft tissue density mass that's present. So in this case, we still kept a diagnosis of granulocytic sarcoma because of the appearance of the lesion, and kept a differential diagnosis of rhabdomyosarcoma. Now, because there was a suspicion of granulocytic sarcoma, we went ahead and did peripheral blood smear. So the peripheral blood smear was normal. There was nothing abnormal that could be detected in that. So we thought, okay, so this is not granulocytic sarcoma, then it could be rhabdomyosarcoma. We went ahead and debulked the lesion, and this is the histology which shows the sheet of cells with heavy mitosis that is present, but Desmond stain and MyoD1 stain were negative, which means that this is not a case of rhabdomyosarcoma. Myeloperoxidase stain was positive. and the bone marrow showed the presence of blasts and presence of mitosis. So this, in fact, was a case of granulocytic sarcoma. So what do we learn from this case? So it indicates that a negative peripheral blood smear does not rule out a granulocytic sarcoma. One, it could be false negative. Two, there is also a component which is called as aleukemic leukemia, where the child would have leukemia, but the WBC count is absolutely normal. Peripheral blood smear is absolutely normal. The changes will be seen only in the bone marrow and in the tissue that has metastasized or the tissue that is infiltrated elsewhere. So these cases certainly require a biopsy. A peripheral blood smear is not sufficient. Now let's move on to case number 3. Now this is a child who presented with a lesion in the left eye, and this is the MRI orbit, which shows that there is a well-defined lesion that is present, relatively homogeneous, slightly hyperintense on T2 imaging. Now this just this picture, it makes a clinical diagnosis of rhabdomyosarcoma. Now, how do we go about this case? So it is very important to do a bone marrow biopsy because 20% of the rhabdomyosarcomas at presentation have metastasis. And the most common site for metastasis for these cases is bone marrow and lungs. So it's very important to do a bone marrow biopsy and do a whole body PET CT to rule out if there is metastasis elsewhere. And the other next important thing whenever we see a case of RMS is that we have to aim to remove the complete tumor whenever possible. And that's what was done in this case, where a swinging eyelid approach was taken and the entire tumor was removed. And this is the histology which shows the sheet of cells, and it had a nice fibrocollagenous capsule. This again, the cells which with very high mitotic rate and arranged in fascicles. Desmin and MyoD1 was positive, with confirming the diagnosis of rhabdomyosarcoma. This is Vimentin again confirming the diagnosis. Once we know that it is a rhabdomyosarcoma, it's important to know what histologic variant is it. This was an embryonal RMS. So why is it important to know? Because it could be a embryonal type or alveolar or pleomorphic. It's important to know because the prognosis depends on that. The botryoid or the spindle cell have very good prognosis. The embryonal, it has intermediate, but the alveolar RMS and the pleomorphic, they have poor prognosis. And that's why it's important to know the histologic variant. And not just that, it is also important that we surgically remove the tumor completely, because the staging of the disease, it depends upon that. When we completely remove the tumor, then we simply don't have to do anything further. We can just simply observe the child. But if there is microscopic residual disease, sometimes which can happen because of the margin being positive, the capsule being breached during surgery, these cases require radiation treatment and chemotherapy. And sometimes when we do just an incisional biopsy where there is a gross residual disease, they require much more chemotherapy and radiation. And metastatic disease, of course, they will be treated by palliative care because the prognosis is very poor. So whenever it's very important to understand that when we see a case of or suspect a case of rhabdomyosarcoma, it's important to aim for complete surgical removal. Don't stop with just an incisional biopsy. Wherever possible, completely remove it. And this was the child after treatment. Coming to the last case. Now, this child, in fact, presented to our clinic just last week. It was a 7-month-old boy who presented with a lesion in the left eye, and the history was very short of only 20 days. And this is the CT scan of the child. This is a very interesting CT. If we see, this is a lesion, a triradiate lesion. What is a triradiate lesion? That means the epicenter of the lesion is the sphenoid wing. And there is a portion of the tumor that's present in the lateral orbit. There is a part of it in the temporal fossa and a part of it in the brain. So that's a triradiate lesion. And whenever we see a triradiate lesion in a child, usually it falls into one of these 4 diagnoses. One is the Langerhans cell histiocytosis or the eosinophilic granuloma, which in fact is a benign condition which can mimic a malignancy, but it will have much more osteolytic changes than what we are seeing here. Second is the Ewing sarcoma, but usually that occurs in older children. Third is osteosarcoma, which has this very classic sunburst appearance of the bone. And fourth, metastasis. Metastasis is something that we think that it occurs only in elderly group, but it can occur in children as well. Now, this child, we did biopsy, and you can see the sheet of cells which have a pseudo rosette formation. Synaptophysin was positive, chromogranin was positive. In fact, this was a case of malignant neuroendocrine tumor, neuroblastoma. So this was a metastatic neuroblastoma. Whenever we think of metastatic neuroblastoma, most often we associate it with eyelid ecchymosis, where we tell us typically the raccoon eyes. But as we can see in this case, sometimes it can present
Okay,
as
if you could please summarize, your time's almost up.
tumor as well. This is the summary of whatever I presented. So it's important to look into the age, the laterality of the disease, look into the imaging features, and always decide when you have to do excisional versus incisional biopsy. Thank you very much.
Thank you very much, Swati. Those were excellent cases and great learning points. We have currently been joined by listeners in Argentina, India, Indonesia, Spain, UAE, USA, Israel, Iran, UK, Singapore, South Africa, Lebanon, Nigeria, Germany, Switzerland, Canada, Pakistan, Thailand, Mongolia, Italy, France, Vietnam, Sweden, Turkey, Hong Kong. So we have an excellent audience. So let me please invite Ganga to proceed with his talk.
Thank you, Aparna and Ashwin. I hope my slide is visible. I'd like to thank you all for the honor of giving us an opportunity to share our experience. And I want to make a big shout out to the energy and brain behind WSPOS, Ken Nishal, David Granat, Ramesh, for their ceaseless energy in keeping this educational activity alive. Due acknowledgements to a lot of the people I learned a lot of these things from, including my accomplices to the crime that I create here in the name of Pediatric Ophthalmic Oncology, our pediatric oncologists, interventional radiologists, and radiation oncologists, lately our proton beam specialists. Radiation is the F word of medicine. Why? Because it's ionizing. Ionizing can be bad. But like any other four-letter F words, fuel and fire, when used with proper discretion, can be put to good use. Most oftentimes, we encounter radiation ophthalmology or pediatrics in the realm of diagnostic and therapeutic effects. So if you look at the various diagnostic imaging, ultrasound is universal there in offices and clinics. CT scan usually is a go-to for imaging modality, and of course, MRI. The problem with the ultrasound is it does not image anything inside the orbit or the brain, and hence by default, CT scan becomes imaging of choice. It's excellent for bony details, pretty good for soft tissue details, not very expensive, can be quickly acquired, but has the problem with exposure to ionizing radiation. Hence, it's not a modality that has to be repetitively used. Hence, if soft tissue things like you see over here, the Pineloblastoma that you see over here, MRI is the imaging of choice for soft tissue lesions. Why are we concerned about radiation? We are worried about the side effects, the deterministic effects related to radiation related to the lens, retina, optic nerve, so on and so forth. And also the stochastic effect where there's a potential risk of inducing malignancies, both in patients with germline mutation and even in patients who do not necessarily have a germline mutation. Hence, I always say that the best radiation is the one not given. So if you're talking about a diagnostic or therapeutic intervention, always think about the justification of imaging, optimizing of the potential, and ensure it's dose limited. So just a few things for you to think about, which we'll touch upon. How much exposure do we even put patients to radiation? And we are worried about it because of the side effects that we see to the globe, the orbit, and the face as well. And so I'd like to call it the good, bad, and the ugly. Like Dr. Swati mentioned, whenever in rhabdomyosarcoma, the more debulking you do, the less radiation you really have to do. So hence the side effects is minimal. It's a good therapeutic effect with minimum side effects. The bad is all the numerous side effects we see in the acute and the subacute phase. And the ugly is where you see craniofacial dysostosis and malformations, including secondary malignancies, osteosarcomas, leukemias, and in young children, neurocognitive abnormalities. Interestingly, when Henry Kaplan designed the linear accelerator for Hodgkin disease, it is retinoblastoma, in fact, that was first ever therapeutic intervention in medicine. So what are the various radiation modalities? We classify them into teletherapies and brachytherapies. What is really new in the realm of radiotherapy is proton beam therapy, and I'll talk a little bit about it. Why is it different? Because its energy stops at a particular depth and does not go through and through, hence causing a lot of the collateral effects, has almost zero exit dose, and can be reduced in very small fractions. And you will see in cases later on where the globe can be preserved even when you're giving high dose proton beam therapy to the orbit itself. Here are examples of photon beam therapy where we don't have a choice except when you have extensive high-risk disease. It's used more as a salvage rather than anything else. Typically, we use it when there's orbital retinoblastoma cut into the optic nerve is positive, scleral invasion, so on and so forth. There's orbitocranial disease, as you can see in this patient with metastatic retinoblastoma in the orbit and intracranial metastasis, and should be contraindicated anytime you can avoid it. And the reason being that second malignant neoplasm is significantly higher with external beam radiotherapy. That's where proton beam therapy really comes in. Focus high dose radiation without any exit dose at all has been shown that the lifetime risk of second malignant neoplasms is much lower compared to external beam. A quick word about brachytherapy. There are specific indications for it when there's residual or recurrent pure intraocular disease, or occasionally in primary disease, which is very small and localized, has the advantage of not having any extraocular collateral damage. But the disadvantages is not universally available. Surgical precision is important. There's an implantation and explantation surgical procedure involved with hospitalization. Here's an example of a patient with posterior pole where it could have been managed with IAC and TTT, but was managed with a single sitting of plaque radiotherapy. There are various plaques available, and most oftentimes it's iodine, which is popular around the world, but ruthenium is a reasonable alternative where the cost considerations really and the repeatability of using these seeds are very useful because of the longer half-life. So what exactly are the indications of radiotherapy in ophthalmic oncology? They can be classified into ocular tumors, surface lesions, and orbital tumors. And I'm going to touch purely on retinoblastoma a few slides, optic pathway glioma, and finally a little bit about rhabdomyosarcoma. So when do we consider radiotherapy in retinoblastoma? In intraocular disease, where there's residual disease, not usually as primary disease, when there's diffuse vitreous seeds, especially in the pre-era where there was no intravitreal chemotherapy available, or there's recurrences after chemotherapy and consolidation. Whereas if you have orbital radiotherapy is indicated where there's post-enucleation, you have any of the high-risk factors, and occasionally with metastatic retinoblastoma, as you can see over here. So why do we still embark on radiotherapy? Because still the globe salvage rate is not pretty acceptable. Enucleation rate really goes down. Between the failure rate between photon and proton is about equal. And depending on what was a pre-treatment visual acuity, a lot of these patients can have visual preservation as well. Radiotherapy, however, in retinoblastoma has a lot of side effects, which we already touched upon a little bit easily. But more importantly, why we try to avoid it is a serious side effect, including these craniofacial deformities, second malignant neoplasm. The cumulative incidence is as high as 36% over a 50-year age group. Brachytherapy is also being used nowadays because it has excellent tumor control with good surgical outcome itself, not only globe preservation, but vision preservation, but still has significant risk of complications, but no second malignant neoplasms. Examples of benefit from brachytherapy. The second thing I'm going to touch upon is optic pathway gliomas, which, as you know very well, can be either low grade or high grade. High grades need more aggressive intervention, but the low grades can be observed. And the standard modality of treatment is chemotherapy with radiation. We try to avoid radiation in very young children, but older children, you can go ahead and do it. There are new targeted therapies coming our way. Here's an example of a teenager who developed an optic nerve glioma and has reasonable vision where you don't want to do a biopsy, but perform radiation maintaining the vision. The third indication where we think about orbital radiotherapy is rhabdomyosarcoma. Dr. Swati touched about it. It's usually a combination of surgery followed by chemotherapy and radiation. Of course, if you have complete resection of tumor, you can consider not using it. But more often than not, there's microscopic disease or gross residual disease. Hence, you will have to expose these kids to radiation. However, more focused it is with proton beam therapy, the better the results with least side effects and not losing vision itself. Typically, RT can be given at the same time or concurrently. Here's an example of a patient who was treated as orbital cellulitis for 6 weeks before he was referred to us. We treated him with the standard protocols with good outcomes. So EBRT always has side effects. Yes, thank you very much. And that's where there are various measures that you can really adopt to try to minimize the side effects, gross debulking, and followed by proton beam therapy. If you have access to it, the arrow marks kind of show you that the globe can be spared even with high dose radiation in the periorbital area. The last slide is upon whole brain radiation. What is the importance in ophthalmology? These are the various indications of extensive disease. But again, there are lesser and lesser indications with the advent of new techniques of radiosurgery, proton beam therapies, intrathecal chemotherapies, and targeted therapies. So I'm just going to summarize, just sharing how much radiation we all get it. For example, in the era of pre-COVID era, when you're doing long distance flights, we are exposed to radiation. And this is cumulated with all these diagnostic imaging. So in summary, I think judicious applications of imaging modalities, X-ray, CT scans, MRI, avoid multiple repeated CTs, avoid in patients with germline mutations and avoid multiple repeated CT images, consider cone beam CT, consider proton therapy and brachytherapy, and important to have preoperative treatment counseling and long-term surveillance. Thank you very much.
Thank you very much, Ganga. That was fantastic. Just to remind everyone about the Menti numerical code, it is 298-44825. That's 298-44825. So please go on there and answer questions regarding that. We have people coming from Malaysia, Chile. Well, I know quite a few people there. So we've had our first Bosnian doctor on the World Society. So Ken's very excited about that, and the team's very excited about that, and from Portugal as well. So really do have people from all over the world here. So thanks for those great talks, and so succinct and important as well. So as a pediatric ophthalmologist, obviously you deal with orbital cellulitis. And the issue about orbital cellulitis is, there's two questions I want to ask, and then we'll go to the audience questions. Swati, is there anything that you could advise people who don't see a lot of rhabdomyosarcoma, but see a lot of orbital cellulitis in the differential? And the second, to you, Ganga, I'm forever stopping my ENT surgeons irradiating my small kids with periorbital cellulitis, a little bit preseptal swelling. Is that an issue you have in Singapore? So, Swati, do you want to answer that first question, please? You have to unmute yourself, please, Swati.
Yeah. So if I understand the question, so it's how would we differentiate rhabdomyosarcoma from infective orbital cellulitis? Yeah. So as I think Dr. Ganga also showed, there was one case where it was misdiagnosed as orbital cellulitis and treated for a while before the correct diagnosis is made. So it's very important to get an imaging done in these cases. I think the imaging really helps us to arrive at a diagnosis, and also clinical features as well. Now, if it is an orbital cellulitis, it would have the signs of inflammation, most of which are not there in rhabdomyosarcoma unless it is associated with extensive area of necrosis. Sometimes where extensive necrosis can cause inflammatory signs, but otherwise, if it is infective orbital cellulitis, it would have the signs of infection and associated with pain, which is generally missing in a case of rhabdomyosarcoma, where they do not have pain. The key feature, I think, is imaging. Always get an imaging done. Orbital cellulitis would probably have the diffuse inflammatory changes that would be present, the soft tissue changes that would be present, but not a well-defined mass that is present in the orbit. So that certainly helps to differentiate orbital cellulitis from rhabdomyosarcoma.
Yeah, thank you very much, Swati. And ideally not CT scans in very small kids. And how about you, Ganga, for that aspect? Do you see a lot of that in Singapore? Because certainly around the world, we see a lot of CT scans in 2-year-olds and 3-year-olds, which obviously is a risk regarding brain tumors related with radiation.
I think there's a very practical question, both from a diagnostic point of view and a therapeutic point of view. It's very important to differentiate between a preseptal and an orbital cellulitis, as you know very well. And one of the most common causes of preseptal cellulitis, sometimes even an acute hordeolum internum or externum, and there's absolutely no role for imaging at all. However, if you do think that there could be an underlying sinusitis, whatever it may be, that's when you talk about imaging. In my book, I still will go for CT scan as a first image, mainly because I want to know both soft tissue and bone anatomy. And I don't do only orbits when I suspect an orbital cellulitis, but I usually do orbit and paranasal sinuses. Let me tell you why. Because if this child or older child or adult is going to go for a surgery later on, it's the same scan that can be used for intraoperative navigation when you need to do it. But if you're doing repeated imaging on these patients, that's when I switch over to MRI and use that to monitor your subperiosteal abscess, orbital abscess, so on and so forth.
No, that's really helpful because it's there and it's quite easy to do, and many people ask for it. What we're trying to do is convince people just to do it when it's absolutely necessary, rather than for any kid with a slight swelling in the eyelids. So I'm just going to go to some questions now from the audience. And I think this is to you, Ganga, again. Is there gamma knife for the orbit? You mentioned it in your talk.
Right. Radiosurgery within the orbit is not as popular as what we see it to be, but it seems like proton beam therapy seems to be very popular. However, it is curtailed in terms of limitations because it's not widely available, very similar to plaque therapies. From the economics point of view, we looked at the numbers, and Singapore is just getting its first proton beam therapy in the next several months, delayed by COVID. We looked at that math and the economics, and we realized that it is actually worth because it's going to minimize a lot of side effects, possibly reduce the number of sittings that is required for proton beam therapy. Whereas gamma knife in itself, the pure orbital lesions, as far as I know, it's not being applied.
Okay, thanks. That's really helpful.
There's
And another question.
Tumors, though, yeah.
Yeah. Another question. This time is for Swati, saying, so the question from the chat: maybe protocols are different in Europe. I believe, this is from the doctor, it was not necessary to remove entire rhabdomyosarcoma, and it didn't affect survival rate. So can we go to Swati and then maybe Kobe about this? Thanks.
Yeah, so at least in our practice, what we have seen is the prognosis, the survival rates are much better when we remove the entire tumor and do the chemotherapy and radiation. I do not have a control study to exactly point out if it makes a difference or not. I understand that the protocols may be different in different countries, so I would like to hear from other counterparts as well what they prefer to do in their practice.
Thanks, Swati. Yes, Kobe first then. You have to unmute yourself, Kobe. Thanks.
I missed your question.
Okay, it's about removal of the entire rhabdomyosarcoma or just a bit of it. Will that affect survival?
Actually, radiation and removal is not enough, and today we have to add chemotherapy. And I think that the big change comparing to what we used to have about 30 years ago is that the combination, not necessarily the total removal, but the combination of the radiation and chemotherapy is the game changer in rhabdomyosarcoma with very high rate of survival.
Okay, that's really helpful. Thank you very much.
Right, if I could ask you one final question before we go on to our next speaker. Sure. Could you briefly touch on the molecular markers in rhabdo? Just briefly, I know it's a talk by itself, but if you could briefly touch upon the molecular markers in rhabdo and how it affects survival.
Aparna?
Yes.
Yeah, so I would, there are different kind of the molecular markers that have been identified for rhabdomyosarcoma. The main one being the PAX FOXO1, which is the significant molecular marker, which has been associated with a poor outcome in cases of rhabdomyosarcoma. But we do not do it routinely in our cases. I would like to hear if anybody is doing molecular markers for RMS as a routine. We do not do it as a routine.
Ganga, do you want to talk about your experience?
Yeah, at this point of time, we do it more of an academic exercise. We just still go by the gross histopathology at this point of time. But I think there are certain other tumors where we run into an end where we really look for molecular markers for targeted therapies. We have cases of carcinosarcomas and so on and so forth, where we're looking for some straw somewhere to throw on top of the tumor.
Yeah, in rhabdomyosarcoma, usually immunostainings are enough.
Okay, thank you very much. If I could invite Amgad for his talk, please.
Whilst Amgad's starting, we'll just carry on with mentioning the other countries that are involved. So we've got Mexico, Algeria, Ecuador, Serbia, and Ukraine. So thanks, Amgad.
Okay. Thank you very much. I thank you very much, WSPOS, for the generous invitation. My talk is a bit different from the intraocular tumors, but it is related to the webinar today. So I'll be talking about the assessment of Horner syndrome in children and its importance. I have no financial disclosures. I'll just give a brief background on Horner syndrome in the beginning for the young ophthalmologist listening to us. It's the oculosympathetic paresis due to the interruption of the sympathetic innervation of the eye and the ocular adnexa. It typically presents with a triad of miosis, ptosis, and anhidrosis. Ptosis is of the upper lid. Sometimes there is some reverse ptosis. The anhidrosis also depends on the level, which also might be a bit difficult to see in children, but that is the classical triad. The causes of it could be as simple as migraines, although migraines are not simple, but it's not life-threatening, or life-threatening as carotid dissection or malignancies. Therefore, early recognition and intervention may be life-saving in Horner syndrome. Typically, the confirmation was in the past by using cocaine eye drops, where it blocks the noradrenaline reuptake and indirectly increases the effect of it, causing dilation of the normal pupil, but the abnormal pupil, which is the Horner pupil, does not dilate. Cocaine is a controlled substance, therefore it is very difficult to obtain and sometimes limiting in terms of time and how easy you can do the test. This is where apraclonidine came into place, where was typically used for the IOP lowering effect by suppressing the aqueous production in the eye through its effect on the alpha-2 receptors. It also has an alpha-1 agonist activity, which does not affect the aqueous production, and that will be important in our next slide. Now, with the Horner syndrome, what happens is the apraclonidine causes the reversal of the anisocoria. So if you see the upper picture here, where the left pupil is the one larger and the right pupil is the one that is smaller, with some ptosis and some reverse ptosis. I know it's very subtle, but it is there. The apraclonidine, what it does is that when you place it in both eyes, on the normal eye, it causes dilation. It causes constriction through the alpha-2 receptor agonist. And on the abnormal eye, it causes dilation due to its effect on the alpha-1 receptors, which have been upregulated due to the effect of denervation hypersensitivity. The ptosis also improves somewhat. So the apraclonidine has been described in the literature as having the same sensitivity and specificity as cocaine test, and due to its availability, some actually recommended it as the preferred test for Horner syndrome. But there were some reports for its concerns and side effects. There were a few case reports, not all reports, but a few case reports describing decreased respiratory rate, somnolence, lethargy, and bradycardia. Although all of them were self-limiting and non-life-threatening and did not need any actual intervention, but they were concerning side effects. And some reports actually went to the length of it, recommending avoiding its use or not at all in children under the age of 6 months. This is where we felt in our practice, we have a slightly different experience, and we wanted to assess what our practice was doing and the safety of it. So we did a retrospective study on the use of apraclonidine 0.5% eye drops that was used in children that presented with anisocoria suspicious for Horner syndrome. And we were aiming to describe the incidence of the side effects, if there were any, because we could not recall any that was happening. So at the UPMC Children's Hospital of Pittsburgh, we used the 0.5% apraclonidine, and we reviewed the documents of the children that had this testing for any side effects reported, noted by the physician or reported by the parents or the guardians taking care of these children. And we also went into the charts to look for the time that was spent under observation for these children. So this is just a background in our practice, and for the young ophthalmologists that are not familiar with the apraclonidine 0.5% test, sorry, apraclonidine 0.5% eye drop test. We use it as an outpatient procedure in the clinic, and we explain the test and the potential side effects to the parents, the guardians, and we do 1 drop in each eye, and we try to do punctal occlusion for 1 minute if possible, and then 30 to 40 minutes later, the test is interpreted. A positive test means that there is reversal of anisocoria, and then we investigate further. We usually try to observe the patient for at least 40 minutes for potential side effects. Now, our results, what we looked into is that we had 46 patients over the past few years. The age range was from 7 weeks, our youngest was 7 weeks, to 15 years. But as you can see here on the graph, that most of our patients were in the younger population. Over half of our patients, we had 24 patients under the age of 12 months. We had 19 patients under the age of 6 months or younger. Now, we had 15 patients that had a positive test. with reversal of anisocoria. And again, this kind of reflects what we talked about in the beginning of the causes, that some of them are not life-threatening, some of them did not need any intervention at all. But if you look at the bottom one, we had a 3-month-old female that on MRI imaging had a left lower neck mass consistent with neuroblastoma, and she was urgently referred to oncology for further management. Observation time, we had an average of about 90 minutes. The shortest was 40 minutes and our longest was 140 minutes for our patients. Now, we did not have any side effects documented for any of our 46 patients that were tested with apraclonidine 0.5% eye drops. This is slightly different from the experience and that was described in the reports. Now, we are not saying that there are no risks and we're not saying that there are no side effects, but we are trying to say that you should not be afraid of the side effects. They are out there, but you should not be afraid of using this test as it will be sometimes life-saving. Now, the take-home points that we are trying to give from this talk is that Horner syndrome is a serious and sometimes life-threatening condition. Apraclonidine 0.5% eye drop test has widely replaced cocaine testing for diagnosing patients that present with anisocoria suspicious for Horner syndrome. The apraclonidine 0.5% eye drops is a safe and convenient test. It has a low rate of non-threatening adverse reactions, even in young infants. The parents and guardians should be counseled adequately regarding the potential side effects, and you should be prepared to manage them should they arise. You should always inform them that you will want to monitor the patient for an adequate amount of time, even if it's in the immediate waiting area, but you need to have the patient monitored, and you have to ask them to monitor the patient at home for a longer period of time as well for any of those potential side effects. The most important thing is if you have enough clinical suspicion, regardless of what the test shows and what the result is, you should still investigate further as it is a serious condition. Thank you very much.
Thanks very much, Amgad. Just carrying on from that talk, the 3-month-old, what did that 3-month-old also have a ptosis at all? And was a 3-month-old in pain, a sudden onset scenario?
So the 3-month-old actually was during the kind of the peak of the pandemic, and she was a telemed visit, and the parents were noticing the ptosis, and then they were asked to bring them into the office, although we explained the risks coming in during the pandemic, and then she had some ptosis and anisocoria as well.
Okay, and that was a sudden onset, was it? And there was no heterochromia there?
There was no heterochromia, no. It was a new onset, and then the parents were describing it that it was different. Again, you're talking about a 3-month-old, but we did the test and it turned out positive. I think the patient was admitted on that same day and had the MRI on the same day.
Okay, and some of these little ones that get acute onset Horner's and neuroblastoma, they're in a lot of pain and they're crying the whole time. Can you remember if that was the case for you?
This one was not, again, a 3-month-old, but it was not nothing unusual.
Obviously in severe pain. Okay, great. So we've
if you could also tell us, if you see a positive Horner's confirmed pharmacologically, what route do you take? Do you send them for imaging yourself? Do you send them to oncology? And if you order imaging, what kind of imaging would you order?
So in our practice, we try to initiate the imaging ourselves. So we actually send the patient for admission immediately. We talk to the emergency team, we talk to the neurology team, we talk to the radiology team, trying to get it done as fast as possible. Most of the time we get it done on the same day. And we usually aim for MRI of the head and neck and urine catecholamines as well.
Great. Just to remind everyone about the Menti code again, all those watching, it's 298-44825. That's 298-44825. So we've got a question from the audience, and they're asking everyone on the panel what they use for pharmacological confirmation of Horner syndrome. And I use 0.5% apraclonidine. I'm a little reluctant to use it in under 6 months, but your presentation may have convinced me that maybe I could use it in that age group. Would anyone else like to add anything?
My practice is the same. I am very careful under 6 months, but I use only apraclonidine. But again, thank you, Amgad.
Would anyone else from the panel who see Horner syndrome would like to add anything at all? No? Okay, Aparna, I think we can move forward and
If
give
you
us
don't mind, can I just ask a question, which is what I think most people as pediatric ophthalmologists worry about? It's physiologic anisocoria. We see it so much. I think they say 20%. So
the main things that you want to look for is you want to look for ptosis, because that is not going to be present with the physiologic, with the Horner syndrome. Now, with the physiologic anisocoria, you might have about a 1 millimeter difference between both pupils that pretty much remains the same in the bright light conditions and in the dim light conditions. But with the Horner syndrome, you do have the anisocoria that is much more evident. The patient was outside, you say, well, I don't see anything at all. And you should do a proper.
You can have a melanoma, and sometimes it's also very rare, a metastatic uveal infiltration of some tumors like pneumoblastoma or leukemia or lymphoma, etc. The clinical symptoms are always the same. You can have in preverbal children strabismus, unilateral strabismus. Leukocoria is retinoblastoma, but sometimes it's a different color in the pupil. That is more. You can see it in smartphone phone pictures. Parents can also show some color change in the iris due to rubeosis, for example. And for advanced disease, you can have also ophthalmia or exudative retinal detachment, cataract, and also, of course, visual loss. As I said, the first ocular tumor in children is retinoblastoma. It affects children of less than 5 years old, and it's revealed, like I said, by leukocoria or unilateral strabismus. These two symptoms required an ocular fundus in emergency. If the examination is not possible or too difficult, refer the children in a center able to perform a fundus or a fundus under general anesthesia. There is some smartphone app, but that I think is not very useful. Here you can see that there is a clear leukocoria. And here you can see that this boy has a strabismus plus leukocoria here. And here there is something strange in the pupil. It's because there is a total retinal detachment. So the mean age at onset is 11 months for bilateral retinoblastoma and 29 months for unilateral retinoblastoma. Fundus reveal one or more white retinal tumors with dilated vessels, intratumoral classification on one or both eye. Here you can see an example. It starts like this, a little retinal tumor with some inside. You can see there is some calcification in the familial retinoblastoma. And this is more advanced disease with a huge retinal tumor with total retinal exudative retinal detachment, or this kind of exophytic form with huge mass with large intravitreal infiltration with dust and clouds and sphere. Another case with a huge retinal mass with here vitreous infiltration, and here is the subretinal infiltration. For the diagnostic, it will be very helpful to do ultrasound, biomicroscopy, and an MRI for staging. You need to know if the tumor is always inside the eye or if you have an infiltration of the optic nerve or extraocular extension. There is also some atypical clinical presentation. It's infiltrative retinoblastoma. It's a diffuse infiltration of the retina without calcification in older child. You can also have massive vitreous seedings and some cellular hypopion with iris nodules. The diagnosis is based on clinical findings, ultrasound and MRI, and please don't do any vitrectomy. This is you see an older boy with a big infiltration of the retina and massive infiltration, cellular infiltration of the vitreous. Another case of cellular hypopion, completely white, with iris nodules and medicels here in front of the lens. In this boy, you have some inflammatory presentation with a huge eyelids edema of the upper eyelid And you can see here that there is a cellular hypopion with many nodules on the iris and on the anterior chamber. Sorry. Don't forget that retinoblastoma is an emergency and it's a deadly cancer. This is a boy that came from Africa, and it took 1 year to came to France. And you can see that there is a huge proptosis with here the metastatic subcutaneous retinoblastoma. It is the MRI. And you see that this is another case. You can see in the MRI that the eye is full of tumor, and there is an infiltration of the optic nerve to the chiasm. If you want to know more, you must listen to the webinar, and then you have some nice study, and especially this huge collaborative worldwide study. The differential diagnosis, there is a lot, but the main is the cause disease, and for malignant is medulloepithelioma and melanoma and leukemic or lymphoma ocular infiltration. This is a classic case of cause disease with the classic telangiectasia and the huge exudative. You can see that it's clearly yellow, and you can look at the pupil. For cause disease, you have xanthochorea, and for retinoblastoma, you have shining bright leukochorea. The other malignant tumors can be a uveal melanoma. It's rare in children, but it represents 4 to 6% of all uveal melanomas. The clinical presentation is not different from its adult counterpart. Tumors can be discovered at an advanced stage of the disease if the child is very young, and the prognosis seems better in children than in adults. You can also have this collaborative pediatric study. This is an example of a 5-year-old with a huge pigmented mass behind the lens. On ultrasound, you see that this mass is partly necrotic. This is the MRI with a huge intraocular mass. So this eye needs to be unfortunately enucleated, and it reveals a malignant melanoma. The medulloepithelioma is the congenital tumor that arises from the ciliary body most of the time. It's an achromic tumor of this cyst inside the tumor, and there is some cyst that can float in the anterior chamber. It's malignant in most cases. The treatment can be conservative, is local, like here. Here you have a local mass in the ciliary body. The children was, the surgery was done by iridocyclectomy that confirmed that it was malignant medulloepithelioma, and we add a plaque to kill the cells that remains. This is another case, more diffuse. You can see that there is cyst floating in the anterior chamber, and this cellular deposit in front of the lens. You can also see something that is quite pathognomonic, that is this notch in the lens. We can see this notch better in this case. This is quite pathognomonic because it's due to the infiltration of the ciliary body that is congenital, and so there is a lack of the fibers of the zonula that explain this growth of the lens. And here you can see that there is cysts also everywhere around. This is another case with a huge intraocular tumor that looks like pigmented. Ultrasound disclose a huge mass, very thick. It could be a melanoma, but it could be also something else. The iridocyclectomy showed that the mass was achromic, and on histology, it was a myogenic tumor that's corresponding to a leiomyoma. This is the last case with a boy that was treated for a malignant B-cell lymphoma. It was considered to be on complete remission, but 6 months after discontinuation of the chemotherapy, he complained of a red eye, And you can see that there is a huge infiltration of the uvea and in the iris with a sort of a cellular deposit here behind the cornea. And the fine needle aspiration biopsy confirmed that it is a relapse of this lymphoma. You can have also exactly the same with leukemia. And this is the children after the restart of the chemotherapy. In conclusion, the diagnosis of ocular tumor in children is difficult and should be done in specialized center. The main role of the ophthalmologist is to diagnose the tumor. So in front of the case with leukocoria, strabismus, visual loss, you should do a fundus with a dilated fundus to look at properly at the fundus. And of course, patients should be referred in a referral center. Thank you very much.
Merci beaucoup, Natalie. That was wonderful. Thank you very much for that. We've got people also coming in from Ecuador, Serbia, Honduras, Ukraine, Egypt, Nepal, and Sweden. So thank you and welcome if you haven't been to these meetings before. So I'd like to next introduce, ask Kobe to speak, if that would be possible. Dr. Per. Thank you.
Good afternoon. I have no financial disclosures, unfortunately. A conjunctival, although a thin translucent tissue, is composed of many histological elements that can be the origin of many types of tumor. The entire conjunctiva is external tissue, and therefore it is exposed to chemical, physical, and biological agents. And because of its exposure, conjunctival tumors are usually diagnosed early. The main groups of conjunctival tumors are epithelial, melanocytic, and stromal. And here, mainly in children, we should add hamartomas and choristomas. Metastatic and secondary tumors are quite rare. Conjunctival lesions in children are nearly always benign. We have rarely malignant tumors like melanoma or lymphoma that is less rare, but usually they are larger and appears in older children. And we will mention later on xeroderma pigmentosum. I will not elaborate on examination technique. You are ophthalmologists, so you know how to do it. Now, in the next slides, some of them will be listed. Those tumors that are marked in blue, there are those who appears in children. The others usually do not appear in children. So for example, in benign epithelial tumors, what we see in children are squamous papilloma and cysts. A squamous papilloma is associated often with the papilloma virus. It can be solitary or multiple, unilateral or bilateral. And here we can see squamous papilloma. And in histology, we see very typical papillary lesion, usually without keratin. Conjunctival epithelial cysts are quite common and can be congenital or acquired. And when acquired, usually they're associated with surgical or non-surgical trauma, and they should be treated only if symptomatic. And here we can see conjunctival cyst. In histology, we see tubular cyst. Among the melanocytic lesions, those who are seen often in children are junctional nevus, compound nevus, and inflamed juvenile conjunctival nevus. Melanoma is quite rare. But we should mention also diseases that are often misdiagnosed as a lesion or tumor, conjunctival melanosis or melanocytosis, in which we have pigmentation of the sclera, and racial or complexion-related melanosis, where we have melanosis usually around the nimbus. Conjunctival neva usually appears in the bulbar conjunctiva and sometimes in caruncle, but not in the palpebral conjunctiva. Any any pigmented lesion in pulpal conjunctiva should be suspicious and removed. This is not the place. Conjunctival junctional nevus is the earlier stage of the nevus, and it may be very flat and often misdiagnosed as PAM, primary acquired melanosis, although PAM we don't supposed to see in children. This is a disease or lesion in adults. And here in the histology, we can see the junction in junctional nevus, the melanocyte in the level of the epithelium. In compound nevus, what is typical in conjunctival compound nevus are the cysts, cystic structures. We see them in most of the compound nevus. And here in histology, we see the junctional area, the subepithelial, and cystic structures are so typical. Inflamed juvenile conjunctival nevus appears only in children and adolescents and is often, if not always, related to conjunctival allergy. They may be worrisome, especially when they grow during the allergic seasons. And what also may be worrisome is the sometimes large feeding vessel. And for example, here we see most of these lesions are amelanotic, but may be melanotic, and with big feeding vessel, we should not worry about it. It's usually not malignant. And here in histology, we see a nevus nest surrounded by inflammatory cells, and here many eosinophils that are typical to allergy. And here in congenital melanosis, we see the pigmentation of the sclera, and here oculodermal melanocytosis, nevus of Ota, that in addition to the pigmentation of the sclera, we see pigmentation on the skin around the eye. Stromal tumors are more rare, and pyogenic granuloma, which is not pyogenic and non-granuloma and not tumor, is the most common. This is granulation tissue, but we may see various types of hemangiomas, and sometimes lymphangioma that usually is involvement in orbital lymphangioma. And here, this is typical granulation tissue. We see here capillaries in chronic inflammatory cells. And here, conjunctival hemangioma, here, big vascular spaces. Other tumors are quite rare in children, other stromal tumors. Among the fibrous tumors, I can mention benign fibrous histiocytoma. I see one of them, and I wouldn't do the diagnosis clinically, or neurofibroma. And here we see this fibrous histiocytoma. Juvenile xanthogranuloma can be seen sometimes. It can be seen over the surface and rarely also intraocularly. And rhabdomyosarcoma usually is a conjunctival involvement or actually extrusion of orbital rhabdomyosarcoma. Conjunctival xanthogranuloma is usually solitary orange, pink stromal tissue tumor, and here we can see it. In this case, for example, we tried to treat medically, but in the end, we end up with brachytherapy with very good results. Lipomatous tumors we don't see in children. We can see herniated orbital fat. It's not a tumor, usually in the temporal side. Lymphoproliferative tumors we do see, and the most common is benign reactive lymphoid hyperplasia. Lymphoma is rare, but exists, and the leukemic infiltrates, like Swati mentioned in the orbital leukemia, can be also involved as a chloroma in the conjunctiva. When we have conjunctival lymphoma in children as well as in adults, usually it's a low-grade malt lymphoma. Here, this is very typical, and I see recently more and more cases like that, benign reactive lymphoid hyperplasia that can be unilateral or bilateral, typically close to the plica semilunaris, but in 2 or 3 of these cases, in a molecular diagnosis, molecular pathology, we found that it's a very low-grade lymphoma. So we should bear in mind. Of course, in children, we see hamartomas and choristoma. We see them only in children unless they were not treated in childhood. And dermoid, mainly limbal dermoid and dermolipoma are common. and we can see sometimes all kinds of choristomas. And this is typical limbal dermoid that each one of you probably see in this clinic. And in histology, we see the dermal elements like sebaceous glands and hair follicle. And this is dermolipoma with hair. And this is a very strange kind of complex choristoma with cartilaginous as well as osseous elements, even with bone marrow. In carbuncular tumors in children, usually what we see is only nevi. Xeroderma pigmentosum is an autosomal recessive disease and ophthalmic involvement limited to the sunlight, exposed eyelid and conjunctiva. And actually, this disease, we have predisposition to the development of multiple eyelid ocular surface neoplasm, such as BCC and squamous cell carcinoma and melanoma. And for example, this girl, she has xeroderma pigmentosum. And here we can see, it's difficult to see because of the brown iris, but here we see in the limbal area and conjunctiva, we see melanoma. Of course, she has also skin tumors. Thank you so much.
Thank you very much, Dr. Pierre. That was an excellent talk with great images. We have an audience from Russia also joining in with us now. We have a question from the audience for Dr. Pierre. The question is, what would be the treatment for multiple papilloma in addition to excision to prevent recurrence?
First of all, of course, papilloma, sometimes they are self-limited, but you can excise them. And usually when it's associated with papilloma virus, we may have multiple, and we can use interferon. Interferon alpha 2b is very popular, although sometimes difficult to achieve, but even interferon alpha 2a.
Thank you. I would like to remind all the listeners that the Mentimeter code is 29844825. I would like to ask Natalie a question. Could you briefly tell us the association of medulloepithelioma with DICER1 and the other tumors that sometimes you have to consider?
Yeah, that's right. In case of medulloepithelioma, you must look at DICER1 mutation, but it's quite rare, and it can be associated with other tumors.
Thank you.
Just going on from that, Natalie, do you prefer plaques when you're dealing with medulloepithelioma, or do you go for enucleations? What's your preferred treatment?
It depends. If it's located, I'm doing a surgery and a iridocyclectomy, and if it's malignant, I add a plaque because it's not possible to do a proper surgery with a safety margin in this case. So I put a plaque to destroy what it remains. And if the medulloepithelioma is diffuse and the eye is full of tumors, you have two options. The first one is enucleation. And recently, there is people that have tried to do some conservative management with intraarterial chemotherapy and intravitreal plus in the anterior chamber to put the chemo, and it can work.
Okay, yes, I haven't heard of that, so that's really helpful.
Yeah, we do the same. We excise, and if it's malignant, we add brachytherapy.
Yeah, that's right. So we published a few papers on medulloepithelioma with my colleague Mandeep Sagu regarding plaques. So plaques is there, and obviously if it's very big, going to enucleation. So Natalie, I want to ask you about the Cradle app, because we used that during the lockdown for our kids. Did you find it successful? So we had one case where it didn't quite work. It was a baby with a persistent fetal vasculature, which said it was normal. And then when we saw it was pretty obvious PFV. Did you find that any problems with the Cradle app?
I'm sorry, but I didn't understand the question.
Yeah. You talked about a smartphone app called Cradle app, CRADLE. So during the lockdown, we were using it for, instead of bringing the patients in very urgently, asking for the Cradle app to be used. Did you find it worked very well for you in that if the Cradle app said it was normal, was it actually a normal child?
No, I don't. I don't think so, because you can see the leukocoria in some direction of the site. Sometimes if you take the picture and the chart is looking straight forward, you can not see leukocoria when the tumor is located on the periphery. So it's not completely reassuring.
Yeah, I agree with that. Ganga, have you got experience?
Yes, I was very excited to hear about it. I think in one of the oncology meetings, maybe Cleveland, maybe when I organized the meeting, tried it successively in several group of patients, including known cases of group D RBs, and it wasn't reliable at all.
Yeah.
So I actually deleted the app.
It's been very disappointing.
I deleted the app from my phone.
You've been involved with that. Okay, that's really helpful because it's not just our experience with that.
Yeah. So I think that most leukocorias that are seen in photography are not real leukocoria, but we have no option but to check the children. Otherwise, we may miss.
Absolutely. I mean, it's a bit of a pain for pediatric ophthalmologists because they do get a lot of children who are normal, but because of the optic nerve that's giving the leukocoria response. But it's the only thing we got, and there's nothing so far that we can use for that. We've also got some doctors from Colombia, Sudan, and Suriname that are here, so that's fantastic. We're going to go through to the Menti results in a moment, but before we go to that, if I could just ask the role of cimetidine for conjunctival papillomata. I've used it and it has worked. Does any of the panel have any comments for that?
I haven't used it.
You haven't used it?
No, I know about it, but we haven't used it.
Okay. Has anyone else used it?
Yeah, I have used it and it has worked in my hands.
I agree with that too. It does work sometimes, especially if it is resistant to other treatments, it does work.
The problem with the evolution of drug formularies, a lot of developed countries have run out of cimetidine. And instead, I've tried using ranitidine, famotidine. It doesn't work the same way cimetidine worked. So it's a disappointment. It's no longer available, at least here.
Yeah, I've seen that. And there's another question, the best treatment for dermolipoma involving the cornea. So my impression is excision, but Kobe, is there anything else we could do?
I don't think so. I think that we should excise it, hoping that it's not too big and doesn't involve the center of the cornea, but usually it's not, and we just excise it.
Right.
So on that note, if it is large, do you do a debulking first? Like if it is large and extending posteriorly, do you do a debulking procedure first so that it is not very large?
We usually try to remove the entire lesion.
And may I ask, do you combine it with the lamellar keratoplasty, the first setting itself?
We don't do.
Yeah, I just wanted to comment on that. Like, I think we have a couple of cases where very large lesions, we have combined it with our cornea colleagues, the lamellar keratoplasty in the same setting. Yeah, we have done such cases when it's like really large and deep as well. Yeah.
Great. So we're going to talk a little bit about something we're not allowed to talk about too much, which is retinoblastoma, for a few minutes. And we all love talking about retinoblastoma. That's why it's so difficult for us.
I am sorry. I didn't know that we were going to talk, and I forget everything about it.
Okay. So we're going to talk about the global disparity in retinoblastoma. So, and what's out there and how the society could potentially help. So coming from the UK, we have RBNet, which Swati is very much involved with, which is an alliance between high-income countries or countries with very good retinoblastoma services and other countries that don't have it, mainly in sub-Saharan Africa. And I know Natalie, I know Laurence Desjardins very well, and she's very involved with the Alliance Retinoblastoma in Paris, which are involved with the Francophone countries in Africa. And we're obviously being involved with the Anglophone countries in Africa and other places as well. And we're trying to move things forward. And during the lockdown, we've been having national multidisciplinary team meetings, which I know Swati's been involved with, to try and increase knowledge and so forth, and how WSPOS can support this. Would anyone else would like to add anything about sort of international? Because obviously the issue is with retinoblastoma, that's what kills kids. And we know that leukocoria and assessment, which is what Toby was talking about, is really important. But has anyone else got any ideas or any thoughts on that? So if we could start with Gunga to begin with, and then we'll just go round.
Sure. We do have both personal connections, and we actually actively involved in the St. Jude Alliance with the retinoblastoma networks linking up countries like Philippines, Myanmar, Cambodia, Vietnam, and of course, United States and South America, Guillermo Chantada from South America. And we've had regular exchange of challenging cases, didactic lectures, whatever it may be. And we've been actually able to make big difference in certain countries which don't have certain technology, red cams, external beams, so on and so forth, primarily convincing the teams and the hospitals investing in this effort. And the screening programs, for example, in Davao, Philippines, has been phenomenal success, which we are now able to replicate in places like Myanmar and Cambodia and Vietnam. So we're excited, but COVID has really affected a lot of kids coming over for effective treatments, and that has been quite a disappointment.
Yeah, but one opportunity is this MDT discussions is really taken off via Zoom, so people can now discuss it with experts around the world without having to come over and hopefully getting treatments in that country, but it depends on the expense. So Swati, do you want to make a comment on this?
Yeah, so I think like first coming to where kind of Ganga led the discussion to, I think COVID has really affected, while all these like, you know, the Zoom MDTs, all those are nice, but in our own country itself, because of lockdown in different states and all of it, we are seeing a lot of recurrences because they've been lost to follow up for quite significant period, not able to get timely, like, you know, the scheduled chemo. So it's kind of become very erratic, the treatment, unfortunately. Just coming to the situation in general in India, I think while we can boost that, okay, we have reached the survival rates comparable to other developed countries, but I do not think we are anywhere close when it comes to globe salvage. Globe salvage rates are definitely not comparable because we really see very advanced cases. We do our effort in trying to increase awareness. We kind of like, you know, have what we call meetings with all the Anganwadi teachers who are basically the teachers for very young children. We try to do educational activities, but yes, we are far behind when it comes to globe salvage.
I see. And Natalie, you must see a lot of patients from Africa come to Institute Curie. Is that correct with Laurence?
Yes, that's right. That's
you
correct.
mentioned one.
But I would like to say that the COVID was very completely catastrophic for retinoblastoma patients. Coming from Algeria, etc., or Africa, even in some European countries that are used to send the child to be treated in Switzerland, France, or Germany. And we need to organize a lot of meeting with teams, etc., to guide and to give guidelines to local ophthalmologists to take care of these children. And perhaps it's for all these countries, it's a way to realize that they need to build centers, specialist centers in their own countries to take care of these children, because the treatment is an emergency, so it's very important.
So trying to get them to another country is not a good idea. So
yes.
By discussing with experts elsewhere is a much better option virtually. So any of the other panelists want to add anything?
Yes, I think you just said, discussion with experts. So I think moving forward, there should be a movement towards creating a rare disease network where less experienced physicians or ophthalmologists or any kind of physician, but in our case, ophthalmologists could seek advice on the more complex or complicated cases. If they don't have access to someone with that kind of experience or with that caliber to just run it by them.
So WSPOS could facilitate that, right? Because they've got the people here.
Retinoblastoma network.
Emails.
Yeah.
To do that.
We see it at Hadassah, Palestinian children from the West Bank and Gaza, even in these days. Actually, we see as many Palestinian children with retinoblastoma as Israelis. And the COVID didn't affect, they just have to come and to do the COVID test, actually mainly for the anesthesia, for the anesthetist. So it didn't affect. It did affect, we usually see quite a number of patients from Eastern Europe, and they cannot come because they have to be in quarantine for 2 weeks, and the expenses are very high, so we don't see them. I must say something. In the 1980s, I established a department of ophthalmology in Kenya, and the only thing we could do then for retinoblastoma is enucleation or sometimes exenteration. And I must say that I'm very impressed with the progress that is done with the treatment of retinoblastoma in developed countries, with the help of all of you and others that really give hands and help treating children in these developing countries, mainly in Africa.
Yeah, no, Nairobi has a great center with Kahaki there. So yeah, it's a really good center.
Brenda Gali really worked hard to establish treatment of retinoblastoma in Kenya, and it's very impressive.
No, it's a good setup there. So I think we're coming to the end now. So thank you to everyone for taking part. I think it's been a wonderful meeting, really. I've learned a lot. And I think just having a few of us and a lot of time to discussion has allowed us to just look at some points that, it's quite easy to miss. But it's been really helpful. So I'd just like to hand over now to Aparna to announce the mentee results, and then we'll be signing off. Okay, thanks, Aparna.
Well, thank you very much. It was an excellent discussion. And just to tie in from the Phoenix standpoint, we usually help with we are in collaboration with a couple of centers in Mexico, where again we had them come over, we trained them, and then we used to have frequent televisits. And again, COVID has hampered it to some extent, but we've been able to continue. It's only that we were not able to bring the kids that were not treated there. So I have the mentee results, and in the interest of time, I'm going to go through it very quickly. So the first question was, what part of the world are you from? And 47% was from Asia, 20% from Europe, 0 from Antarctica, that's good. 7% from South America, 7% from North America. Australia 0 because the timing doesn't work, but I'm sure they'll watch the YouTube video later. 13% from Africa and 7% from Middle East. The gender differentiation was 63% females and 38% males. By age, 44% were in the age group of 41 to 50. So that was the most common age group. And by specialty, 69% were pediatric ophthalmologists, 13% were adult ophthalmologists, and 19% were ophthalmologists in training. Regarding the questions based on the talks, the first question was, which histological type of rhabdomyosarcoma has the best prognosis? Sorry. And 50% answered embryonal. The next question was, please sequence the following in order of increasing radiation exposure. And the order was X-ray. The most commonly chosen order was X-ray, MRI, CT, cone beam CT, and PET CT whole body. The correct sequence is actually MRI, X-ray, cone beam CT, CT phase, and PET-CT. That's the correct order. The next question was, do you use apraclonidine eye drops to test for Horner's syndrome? 46% said yes, and 46% said no, they do not use apraclonidine. Okay. Okay, and then the next question, which type of the following conjunctival nevi appears almost only in children and adolescents? 50% said junctional nevus, 17% said subepithelial nevus, 25% said inflamed conjunctival nevus. And the correct answer is actually inflamed conjunctival nevus, but that's exclusively seen in kids. And the last question was, what, according to you, was the best part of the webinar? And everybody answered that it was the discussion. Okay, so I would really like to, first of all, thank all the panelists. I have certainly learned a lot, and I look forward to further webinars like this. And I would like to thank WSPOS for putting this together. I would like to thank our WSPOS administrators for doing such a good job with organizing this week after week. And I would also like to thank NTOD, who is the sponsor of these webinars. The upcoming webinars in season 2, May 29th, we have unmet needs of amblyopia. June 5th, it's update in ophthalmology. June 19th, we have a wet lab on virtual strabismus. June 26th, it's on ROP, and July 3rd, it's on infantile nystagmus syndrome. There are a couple of other webinars that are being planned, one on electrophysiology and the second on ocular pathology, and definitely we will update you about the same. We really encourage you to join WSPOS. The membership is free, and this is the website, www.wspos.org. You could also join the Facebook page, and you can subscribe to the YouTube channel. We also encourage you to join Dr. Granite's listserv. You can email him at dgranite@ucsd.edu, and he would be happy to include you in the listserv. So thank you very much, and have a very good rest of the Saturday, or good night to all of you.
Thank you.
Thanks,
Thank
everyone.
you. Bye-bye, everyone.
Bye.
Thank you very much.